Good evening to all of you. My name is Brent Stevens. I'm the superintendent of Berkeley Unified School District. Thank you very much for joining us this evening. We are very pleased to be partnering with the University of California at San Francisco to offer a special seminar to families here in Berkeley that will just take on a whole variety of questions related to health and COVID-19. We're very pleased to have a number of very special guests with us. I'd like, as we, before we just turn right over to those guests to both introduce themselves, share some information and field questions, let you know that this event sort of was masterminded by Natasha Beery. Can you wave at everybody, Natasha? Natasha, if you have not met her, is both the director of our Berkeley School Excellence Program and director of community relations. And so in those two roles, has lots of opportunity to engage with the Berkeley community. So Natasha, thank you very much for all the work that you put into putting this together. We really appreciate it. And then it may be the case a little bit later in the evening that we get to some live questions. We've actually derived the questions for this evening's presentation from the community's participation in the Thought Exchange survey that went out several days ago. So our panelists are on hand to answer those questions, and I'll plan to attend the entire session as well and can answer questions if needed from a BUSD perspective. So with that, I'm turning it over first to Natasha, is that correct?
And I'm going to turn it right back over to Dr. Lee Atkinson-McAvoy. Please take it away, Dr. McAvoy.
Welcome, everybody. Thank you so much.
All right, thank you guys for sharing your Monday evening. My name is Lee Atkinson-McAvoy. I'm a professor of pediatrics at UCSF, and I'm here with two of my colleagues, Dr. Mitul Kapadia, who's an associate clinical professor of pediatrics, physical medicine, and rehabilitation, and Dr. Elizabeth Rogers, who is an associate professor of pediatrics. The one disclosure that I have to make is my husband, Michael McAvoy, is a teacher at Longfellow Middle School. And so I feel a connection to Berkeley Unified. We're here to really talk a little bit around the science of COVID. And this talk is based upon a talk given by our colleagues who've partnered with Oakland Unified. So some of you may have seen the video from these providers and colleagues around how schools can reopen safely. Again, we're here to be a partner to families, students, teachers, and staff, and we really want to provide you with trustworthy scientific information on how to reduce COVID risk. We're really just here to offer our expertise. The decision around how and when your schools reopen, it's up to your school district. We also know that new data comes out constantly, so what may be true today can change tomorrow. And these slides were, I want to say, updated last week, but we may have put a few things in the last couple hours to make sure we are most up to date. So we want to ground sort of how we are starting to talk about COVID in terms of thinking about trauma-informed systems. The image that you see was done by an artist, Kadir Nelson. It's called After the Storm. And he created this painting at the start of the pandemic to really remind us about connection and closeness that many of us long for. And this is one of the key things to think about as we think about how we are approaching the pandemic. It is a trauma that we've all experienced. And we really are committed to giving you as transparent information as is possible. The goal is to identify the safest way, not only for the students, but for the teachers, the staff, the community, and the families of the students to safely re-engage in in-person learning. We'll talk a little bit about racial equity because we know COVID has affected different populations differently. And we're here really to collaborate and empower you as a group to make the best decisions to drive recovery and resilience. So we're going to start by talking a little bit about health equity in COVID. Then we'll move on to COVID transmission, spend a little while talking about risk reduction, and then we will touch on some of the variants that you've seen in the newspapers. So just a snapshot. Where are we now with COVID-19? So this was a graph from a couple days ago from the Alameda County Department of Public Health site. It does include Berkeley's separate public health agency. And just really to show you that we got through that peak of cases over the Christmas and New Year holiday. And now as we get into March, our numbers have really dipped to some of the lowest that we've seen since last spring. As you've heard, the state has a dashboard. Currently, Alameda County is at tier 2, but if you look at some of the individual numbers, we're sort of transitioning into the tier 3 or the orange tier, where our adjusted cases per day are now 3.6. Our overall test positivity rate is 1.5. And then the lowest quartile for our healthy places index, which looks at populations or areas where there is more risk of COVID transmission, is also low. So for all of these metrics, we're in the orange tier. We just haven't been there long enough to officially move to that tier. So I want to touch a little bit on health equity and COVID-19, because we know that COVID has not affected all of us the same. We do know that there has been a role of racism and medical abuse that is historic, and that has led to lots of mistrust of healthcare systems and medicine. We know that poverty, educational gaps, housing instability, and lack of healthcare have put certain racial and ethnic minority groups at higher COVID risk. We also know that some of the initial strategies were slow to spread, and that caused harm in certain communities, including, besides illness and death, lost wages, increased stress, and other consequences. A snapshot for California of the differences: the death rate for Latinx people is 22% higher than the statewide average. The case rate for Pacific Islanders is 32% higher than statewide. The death rate for Black people is 6% higher than statewide. And the case rate for communities with median income of less than 40,000 is 38% higher than statewide rates. And COVID-19 just highlights the existing inequity. We know for those populations, there's nothing about biology or genetic makeup that makes the difference. It is really structural racism and the barriers to care and the difference in risk of exposure that exists amongst the different populations. We see the same differences mirrored in Alameda County, where that top gray line is our Latinx population. And we see discrepancies between Latinx, Black, and some Asian populations at different points along the curve. We've also seen some inequities in the exposure of our students. We do know we've seen issues around grief and loss of loved ones, but grief and loss of the norms of life. Isolation, multiple people sharing limited space at home, lack of access to healthcare, childcare, and even distance learning tools, despite schools giving out computers and hotspots. We know there's increased risk of depression and anxiety, and there's some early reports to suggest that we are seeing these in our children. President Biden, when he created his COVID response, created a COVID equity task force, and I think it's worth looking at the quote from the co-chair. We started with different levels of awareness at the beginning of the pandemic about the legacy of systemic structural racism and inequality. It does feel different now. There is this awareness, in some an awakening, and in everybody a reckoning. What keeps me up at night is misinformation and disinformation and how fast it's moving. I wouldn't have predicted that in the throes of a national pandemic, there would be actors pushing intentional misinformation, often targeted at the very groups that are suffering the greatest. I'm hoping, as part of the new normal, that we really restore trust in science and evidence and data. And we are here today to share with you that science and evidence and data to help inform you to make a wise choice.
I'm going to jump in now. We're going to talk a little bit more about the hard science of what we understand about transmission and the ways we can mitigate the risks of transmission, particularly in the school setting. And as Dr. Atkinson McAvoy had said, this in particular is a very good example of how our understanding has evolved over time. Our understanding about COVID and transmission risk a year ago in March of 2020 was very different than it was in the fall of 2020, which is very different than where we are now. And that has been reflected in the way that our behaviors have been. I remember a year ago when I was coming home, I was cleaning my groceries every time when they came home. When I would come from the hospital, I would change clothes, I would clean my shoes, I had a separate arena. And that was when we thought that surface transmission was a significant potential profile for how COVID spreads based on what we thought of other respiratory illnesses. And that has evolved over time. And that's partially what has led to some of the confusion, because some of these changes have evolved and have moved in terms of how we think we can maintain safety in the school setting. So the way that COVID is transmitted between people is to get infected. You get infected from your nose, mouth, or eyes, making contact with respiratory droplets from an infected person when they exhale, speak, sing, cough, or sneeze. And so those respiratory droplets, we kind of term that as droplet transmission. And those droplets we think can transmit about 2 meters or about 6 feet in a community setting. The second kind of transmission that can happen is airborne transmission, where those smaller droplets can evaporate into the air. And we know that's particularly higher risk in indoor settings, and particularly in indoor settings without good ventilation systems. And it's significantly less of a profile for how COVID is transmitted than droplet transmission. The third way, as I had just indicated, is surface transmission. And that's when someone coughs or sneezes on a surface, someone else touches that surface with the viral particles on there and then touches their face. And that's not thought to be a significant risk, although it is still a possible way of transmitting coronavirus. So what we call a high risk exposure is having close person-to-person contact. And the way we define that is greater than 15 minutes over a 24-hour period within 6 feet. And that's what we consider to be a high risk exposure, both in the hospital as well as in a community setting. And we'll talk a little bit more about the differences in the school setting at a later slide. Next slide, please. One back, Doctor. Sorry, go ahead. Okay, so there's kind of 3 stages that we can think about how respiratory transmission occurs. So the first step of that is the person that could potentially have COVID-19, and viral particles are expelled through respiratory secretions. And that can be from coughing, sneezing, but that can also be from exertion, doing sports or singing or doing something that creates those particles to be released into the air. They survive the flight through the air. I mean, like I said, we think that's about 2 meters or about 6 feet. And then they land on the face of another person or on a surface, and that person can touch that surface with that viral particles and then touch their face and can be transmitted that way. So our mitigation strategies are very much based on creating barriers between that transmission process. So there's ways to minimize exposure. So those can be both home-based or school-based screening of symptoms. Masks, which are a way for the person that has the virus to limit the amount of exudate that they're creating of those particles. Cohorting, and particularly in the school setting, we're talking about cohorting students in the classroom so that there's less mingling between different groups of students. Testing and vaccinations, which Dr. Rogers will talk a little bit more about. There's ways to mitigate exposure, and that's keeping distance from each other. Being outside, we know that outside or improving ventilation are important means to decrease the amount of transmission or the efficiency of transmission that can occur of the viral particles. One-way traffic flow, which is another way of trying to minimize the amount of spread between cohorts, the amount of contact or high-risk contact that can happen between cohort groups. And then there's physical obstruction, which is the person on the other end of it wearing a mask as well, or other facial coverings, such as goggles or face screens, and then physical barriers. And that can be things like plexiglass or other barriers that are also created between people. So risk reduction is really where we're focused on. And a good way of thinking about this is kind of that Swiss cheese model of defense. And what that really focuses on is the fact that we don't have a single tool in our arsenal that by itself can eliminate or even significantly decrease the risk of preventing the spread of coronavirus. And so each layer that we have of this Swiss cheese model has imperfections. So the more of those layers that we're able to stack together, we know we have a much better profile in terms of mitigating the risk of transmission. And some of these are personal responsibilities, things that we can all individually do or students can individually do in the school setting or teachers. And then there's some shared responsibilities, things like ventilation, which can be done kind of structurally to help mitigate the risk of transmission. As we were talking about the Swiss cheese model, we know that the pieces of these slices of these cheese have also evolved over time. We know that there's more importance on certain factors as we've learned more about how COVID-19 spreads. And some of those I put in bold, in particular physical distancing, which we're going to talk about at a later slide in terms of mitigating the amount of contact people have, close contact people have with each other, staying home if you're sick. Masks is a big one, and that's something that has evolved over time in terms of what how we understand how masks have a significant factor in terms of mitigating that droplet transmission. Hand hygiene, which is really important, particularly for our young learners. Cough etiquette, which means using your elbow, or if you're not wearing a mask when you're coughing or sneezing. Avoiding touching your face, and masks help with that. Any sort of face guard helps with that, particularly for young children in terms of decreasing that tendency for putting their hand near their face. If you're in crowded environments, particularly when you're mixing cohorts, we want to limit the amount of time that those cohorts are in close contact with each other. And then some of the shared responsibilities, stable cohorts is a big one, which is why it's bold. Having fast and sensitive contact tracing, ventilation, which Dr. Rogers will talk about. So one way we can do that is trying to move more of our activities outside, or air filtration systems that can help prevent the refiltration of air, which can increase the risk of transmission. Quarantining and isolation, so having a good system in place to being able to identify cases and then doing contact tracing and managing the downstream effects of that. And then vaccinations, which is a big one. And this time we're really talking about vaccination of our teachers, our administrators, our educators, while we're still waiting for the profile for vaccines to become more available to our children. So we're going to kind of go through these slices so we have a little understanding of how we can layer these slices together to really minimize the amount of risk of transmission that can happen in the school. So slice one is really staying home if you're sick. And that means screening all of our students, our administrators, or educators prior to them departing for school. Students should stay home if they have symptoms in a student or a family member within the 24 hours prior to that day for a day of school. If anyone in the family is waiting for a non-routine COVID result, and a non-routine COVID result means that they have symptoms or they had a high risk of exposure, and that's the reason that they're being tested, as opposed to a simple asymptomatic test. Any high-risk COVID-19 exposure or COVID positive household contact means that they should stay home. And again, remember, we define high risk as being within 6 feet of someone else that's COVID positive for more than 15 minutes over a 24-hour period. Temperature checks, I know that's a question that has come up, and the more we've looked at temperature checks, and this has been studied quite often, we've actually learned that they're not very effective, require a lot of resources. Dr. Fauci himself described it as being notoriously inaccurate. And that's because there's a lot of different patterns for how fevers and temperatures happen. I mean, when you're doing a simple check, for example, at a school site, you're really just getting a spot check that's not very accurate of whether or not that's a true fever. And there's a lot of inefficiencies in that process. And so generally, we have not recommended universal temperature checks as a way of trying to screen children. It's much more important to do those symptom screens at home prior to arriving in school. So slice two is the physically distance, and this is something that has evolved and will probably continue to evolve as we have a better and better understanding. And this is really reflective of the science that we know now. We've had studies done all over Europe and in states, in rural, urban, in every arena in this country that have led us to kind of changing our ideas about what we need to do to keep our students and our teachers safe in the school setting. So the current CDC guidance, which was just released last week and has also been incorporated by the California Department of Public Health, is that student-to-student distancing, particularly in our younger age children, so elementary school children, should be at least 3 feet apart. In middle and high school, they should be following the same parameters of at least 3 feet, unless there's high levels of community transmission. And that in our case would be deep in the purple level, which we would go back to 6 feet. 6 feet is still very important, particularly between adults, so between teachers and administrators, and between adults and students. 6 feet should also be our distancing component when masks are not being worn, for example, during lunchtime or snack time, and during activities with increased exhalations. So that can be singing, that can be band, that can be physical education or sports activities where there would potentially be a higher profile of droplet production. Masking is also very important and is something that has also evolved over time. I know there's often a question of what is the ideal mask that we should be wearing, particularly for our kids when they're going back into school. And there's a lot of different options that we have available. The general idea is that we want to wear masks that are tightly woven together. So cloth masks like cotton masks do a very good job, but you want to make sure that they at least have 2 to 3 layers. So single layer cloth masks are not as effective, and they're obviously reusable, so something that can be washed and reused again. Disposable masks, which you can think as a medical or surgical mask that we see in the hospital, are 3 layers of tightly woven fibers as well, are also very effective in terms of that droplet transmission. N95 masks are much more specialized. It's important to remember that N95 masks even now are still in high demand, and we still have shortages in the places that need them, particularly in medical settings. So we're really focusing on using N95s in specific settings, such as medical settings, or even in school settings where we think that there's a very high risk potential of transmission occurring. Double masking, which is something that we've gotten a lot of attention on recently. And when we talk about double masking, we're talking about using a disposable mask underneath a cloth mask. It doesn't mean using 2 disposable masks. It doesn't mean using 2 cloth masks. But double masking has shown to be even more effective than using either a cloth mask or disposable mask in isolation over a number of different studies being done. Another important thing to remember is that we shouldn't be wearing any mask with a valve. And the reason being is that what a valve does is it does filter out air coming in, but it lets particles coming out. So it kind of defeats the purpose of creating that barrier between people, because you are still allowed to have droplets come out of those valves. A 4th slice is hand hygiene, particularly for our kids before they touch their face. So hand sanitizer is fine if hands are not visibly soiled, but if they're soiled, if they've been interacting a lot with particles that are making their hands dirty, they should be washing with soap for at least 20 seconds before and after eating and after using the bathroom. I think that's particularly important to emphasize for our younger children, our elementary age children, because this will be a little bit of a shift. We've always emphasized hand hygiene, but I think this is going to be something we're going to have to prioritize, particularly back in the school setting. And so we need to teach and practice hand washing with regular times throughout the day, especially for our young learners. One of the things we do like to mention is that what we used to think about this deep cleaning or this deep sanitation of all of our surfaces is less useful for what we know about how COVID transmits now, rather than emphasizing that importance of regular hand washing or using sanitizer in order to prevent that contact of potential particles to our face. So slice 5 kind of goes hand in hand with what we just talked about. So we want to make it harder to touch faces. So face shields is an option, but it's important to remember that face shields are not a substitute for wearing a mask. They still allow a lot of open entry, both from below the face shield or from the sides. And so if you want to wear a face shield as an additional area of barrier like we do in the hospital setting, you need to wear a mask with it as well. And the conjunction of those two is very effective. In slice 6, which is minimizing time in crowded space. And you can see this kind of picture here of students distance themselves in the hallways. You see a one-way hallway, and this is a very effective means of trying to limit the amount of interaction different cohorts of students can have. So other things we can do is using a staggered approach. During times when we expect abundance of students are being in a similar area at the same time. So staggering arrival time to school, staggering departure times is an effective way of doing that. Staggering class times to minimize the amount of interactions or close contact that's happening in the hallway. And then staggering lunch and bathroom times. Again, trying to limit the amount of each cohorts being in potential close contact with other cohorts of students. And I'm going to let Dr. Rogers take over.
Thanks so much. I'm so happy to be here and talking with you all, and to continue on in addressing our various slices. We want to talk a little bit about testing and contact tracing, because we know that this has also been sort of difficult to follow as certainly information in the science has evolved with testing. And we want to be clear that there are different types of testing, and these all can have a role in school, but some are more important than others. So there's certainly symptom-based testing, which is very important. If a community member has a symptom of COVID and might be caused by COVID, then that is a symptom-based test. And while someone is undergoing a test to evaluate for possible COVID-19 infection, that person is presumed sort of to be at this point, potentially infectious. And so someone awaiting a symptom-based test, as Dr. Kapadia mentioned, needs to really isolate from the community at that point. So that's a symptom-based test, someone who has one of the very known and now very well described symptoms of COVID-19. Then there's testing because someone has had an exposure. And this is somewhat different. And we've learned certainly from the many states where schools have been open that we really try hard to use those early slices to make sure that nobody with a symptom is allowed to be in a school community or in any other community really. But let's say that someone does end up testing positive for COVID-19 and was in community with someone else, whether or not they're were wearing masks, et cetera. Then there might be a role for exposure-based testing that happens because someone has met the criteria for contact tracing. So when someone or a group of people are exposed to COVID. And so we talk a bit about this kind of testing when we talk about cohorts that have met the criteria for being in close contact, might need to be asked to stay away from the school community until they have allowed the appropriate amount of time to pass to see whether transmission happened from that actual exposure. But again, what we've actually learned from the states that have been open is that even when there have been some positives that have somehow gotten through the holes into a school community, the actual transmission from an exposure, as long as masks and the other slices are being held, have been extraordinarily low. But that we'll talk about exposure testing. And the last, I think, is confusing to a lot of communities because that is monitoring or asymptomatic testing. And this is the kind of testing that might be happening on a weekly or biweekly basis of entire communities who don't have symptoms, but it's really monitoring the different layers of prevention and risk mitigation strategies that we've used. This one's a little bit trickier as school communities and whole districts think about how that might be implemented. But certainly its purpose is different than the other two types of testing. And the purpose is if someone is asymptomatic and ends up testing positive, that we actually do remove them from the school community to prevent any possible exposures. Next slide. The next slice is maximizing ventilation. And certainly this was something that as we learned more and more over the spring and summer, we understood that there was the potential of reducing the spread of COVID-19 by really enhancing ventilation in spaces. So this is a figure that really speaks to the importance of increasing outdoor air change rate. So enhancing ventilation using existing systems like doors and windows, and then considering eliminating any recirculation. So we want any of those particles micro droplets that might contain virus to not just circulate in the air, but to actually be brought outside and exchanged for fresh air from the outside and not just recirculated in the room. Certainly there's the possibility of portable air cleaners. So with mechanical filtration systems to capture that airborne micro droplet when there are areas of known air stagnation, where windows cannot be opened, where doors cannot be opened. And so what's important about that is that adequate replacement of those filters has to happen. And then we really want to avoid overcrowding to allow for that air change rate to really be optimized. Next slide. One of our great collaborators actually had a slide that I think I didn't make it in, but I want to be clear, actually, if you want to go back to the ventilation one, sorry, Dr. Atkinson McAvoy, I want to be really clear about this one. You don't have to have HVAC, all of these sort of alphabet soup, different types of ventilation strategies. If there's truly stagnant air, some of the HEPA filters can help, et cetera. But just having 2-point ventilation alone, a door and a window open so that you can have an increased air change rate, has been shown to really provide adequate ventilation. So there are many ways of doing this without having special systems and just utilizing what's available in the classroom. So next slide. So there are a lot of questions about vaccines, and certainly to harken back to what we started with, all of these questions are valid as folks really consider whether they personally want to take the vaccine. But I will say, when you look at all of these different slices of cheese, this is the biggest one. We certainly have been surprised and grateful that vaccines have turned out to be as effective as they are. They're some of the most effective vaccines that have really ever been developed. And certainly they are in many ways the key to getting out of this pandemic. And as we really sort of scale up the use of vaccines, we do want to consider it another piece of the kind of another slice, because we really need to reach that idea of herd immunity so that we have vaccination that can really protect our whole community. In the meantime, all of those other slices add up so well that vaccine has not been thought to be something that is necessary for in-person learning, but certainly we know from an individual basis, it is really one of the really key factors. But again, there are a lot of historical inequities, including structural racism, medical experimentation, and communities have been really differentially impacted by vaccines in the past. And all of those, for all of those reasons, it's really critical that we build trust and we really have relationship-centered communication around about taking vaccines. So are they effective? Yes, we know they are extraordinarily effective. There have been 5 vaccines developed, and all of them are effective when we consider the difference between a flu vaccine, for example, that is fairly standard as a seasonal vaccine. With this vaccine, it's sort of out of the water, blows it out of the water in terms of the effectiveness. And we also know that states or countries, like Israel and the UK, where vaccines have been rapidly deployed and disseminated and getting really high vaccination rates, the rates of infections are really quite plummeting. So next slide. Of course, the question is, are they safe? And that's certainly a question that we're hearing from folks. mRNA is a technology that's been around for a long time, but not utilized in this way. And so I think people were asked a lot of questions around how quickly we were able to develop a new kind of vaccine. But really, there were years of research in the technology, and absolutely the same standards applied to the development and testing of the COVID-19 vaccine. The trials have been done in ages 16 and over, and there are current trials right now. Moderna has a very active adolescent trial, as does Pfizer. Moderna is actually going down lower now. So our hope is soon we will have safety data as well, so that our students can also be vaccinated in the near future. What are the side effects? Most are relatively minor. We're hearing
Did Dr. Rogers freeze?
It seems that we've lost Dr. Rogers.
Okay.
Dr. Rogers, are you
Sorry.
back with us?
I am back. I apologize. I think those are my 4 children in my house. I'm sure using up all of my Wi-Fi. Probably right as I was trying to make a really important key point about there have not been any deaths linked to vaccines, and really very, very rare allergic reactions as the major side effect. And there's no live virus, and therefore the vaccine cannot cause COVID-19. Sorry, next slide. There are very few, if any, reasons not to get vaccinated from the science perspective. Again, we want to make sure that folks are engaging with their healthcare providers in the community. But from the scientific perspective, really the only reason is a very severe, like anaphylactic reaction to a vaccine in the past or to the first dose of the vaccine. So we encourage everyone to talk to your doctor. Actually, pregnancy has been added as one of the reasons to get it sooner, as we've been able to collect more data. And in fact, there's really good data coming out now as well about breastfeeding and being able to pass on those antibodies both through the in utero, so while you're pregnant, and then through breast milk. So for those who are pregnant or breastfeeding, the community was concerned initially, but not only is the data showing that it's safe, but actually really effective at protecting a newborn as well. But if you take medications that suppress your immune system, or again, if you've had a history of anaphylaxis, these are things to talk with your provider about. So this I did just pull off of
I'll take over for Dr. Rogers till she comes back. We went to the Alameda County site. This is the current vaccination rate in Alameda County. So you can sort of see what the rates are for Berkeley. 36.5% of the population has gotten at least 1 dose, and 21.4% of the population has gotten 2 doses. And this dashboard, every city, every county has a similar dashboard. You can look it up at any time to get the data in real time. Go on, Dr. Rogers.
Thank you. Yeah, of course. We can go to the next slide. We did want to talk a little bit about variants, because again, this is one of the things that when we see the news, we want to be clear that variants happen with all viruses. And so really, this is not something that is new or unexpected for us. And new variants, we have to be cautious as they come out. But we've absolutely shown that the same risk mitigation strategy have been effective against the variants. And in fact, Johnson & Johnson and the AstraZeneca vaccine have all been tested when the variants have been in wide circulation. So I see someone saying, respectfully ask my kids to take a break. I was just joking. They're actually not on Wi-Fi, but that was my standard joke. So I apologize. I definitely blame the San Francisco Wi-Fi for that. I think next slide. Perfect.
I'm going to stop sharing because part of this is an opportunity for you to ask questions. So Natasha's going to lead us through the questions that were already submitted, and it looks like there's a few in the chat so far. And if you have other questions, please feel free to add them in.
Thank you very much. Thank you to Dr. Atkinson-McAvoy, Dr. Kabadia, and Dr. Rogers for your time so far, and what we've done to what we hope would maximize the use of your time and of everyone else's was to ask in advance what everyone's top questions are. And so we used a tool called Thought Exchange, and I gathered the top 12 questions that really have some component of trying to understand the science or the medicine around COVID or around risk and transmission. I'm also keeping track of what's popping up in the Q&A, and I'm going to interweave those questions that are arriving with the ones that we had from before. When I look at the questions, what I see is what Dr. Kapadia referred to, which is a number of questions that arise from people trying to keep up with the evolving understanding of the disease and of best practices. And sometimes that changing understanding and the changing guidance is leading to some mistrust and, what's really real. And also seeing, that people have different levels of risk tolerance and different questions about which slices of the cheese to focus on, understanding that they're all important. So with that, as a preface, I would, here are the questions basically in order of popularity. And the first one is one about surfaces. That was one of the first things that everybody worried about. And so now people are wondering, given that kids in Berkeley Unified or elementary kids are going to go back to school, and ordinarily there are shared objects in the classroom, or maybe they're playing sports and there's a shared ball. We do have practices in place, but is that a slice to be really worried about? So that's the first question.
Sure. I can take that one. And Natasha, I think this has been a challenge, I think, for all of us. And a lot of before I'm going to take one step back, our initial thoughts about coronavirus were based on our understanding of other viruses and other respiratory viruses. And a lot of our decisions that we made back in March, including schools, were based on that data. And so we've really had to adapt to the science, adapt to the experiences of schools in Europe, all over the country, and make real-time changes in our processes. And I know that's very challenging to do and challenging to understand for a lot of different people. Surfaces is a perfect example. And as I was saying, we initially thought, because we know other viruses like stomach bugs that cause gastroenteritis do primarily transmit through surfaces or have a primary means of transmitting. And so that was our initial assumption with coronavirus, but that has really evolved over time. We still do think we need to take some precautions. And so we want to discourage sharing of items, particularly ones that are difficult to clean. So things like art supplies, pencils, staplers. And so one of the recommendations that is generally coming from the CDC, the American Academy of Pediatrics, is trying to have separated kind of belongings of supplies, ones that are easier to separate between students so that we're not having as much contact. The risk, again, is of actually having droplets put on those surfaces, another child touching that surface and then touching their face with it. That can cause that transmission, but it is much less likely to occur than that direct droplet transmission that can be mitigated with regular mask wearing and distancing. I hope I answered the question.
Great, thank you.
I just want to make a point, Natasha, on that, especially as we're dealing with elementary school kids, the kindergartners, even if they have their own supplies, they may touch somebody else's supplies. It doesn't mean, it's a time to panic. That's why we really emphasized hand washing, because if you see it happen, a little squirt of hand sanitizer and the problem is all fixed, right? So if the child washes their own hands or cleans their own hands, that is an important slice of cheese in prevention.
Yeah, and there are obviously some things that kids are going to have to do together, whether it's, they're going on the carpet together, the rug together, they're using a computer that we can't have one for, there's things. And so again, what Dr. Atkinson-McAvoy is right on, the emphasis has to be on cleaning our hands before and after touching those potential shared objects, just like we've kind of adapted to doing out in our community as well.
Great, thank you. And the next question about masks, actually several related questions about masks. Everyone's trying to figure out, there was that slide that showed, that there are multiple options. And so people are wondering, how, is it important to do the double mask? Is that the ideal? Does one of those filters, does that count as a layer is another question. And then one person who voiced concern about masks, the concern about whether you're rebreathing and whether that's unhealthy and do kids need to take breaks?
I'll answer the last question easier because we don't think so. We've seen masks being adapted in schools all over the country, even down to age 2 effectively, without having that risk happening, and kids and adults are playing sports and doing physical exertion with a mask. So I don't think that's a concern. In terms of the types of masks, the filter ones that do come in, some of those cloth masks are very effective. It does create that 2-layer barrier, which is more effective than using a single layer, as I had mentioned. So certainly using those filters is very effective. Double masking is something that we've learned more about recently, and the studies have actually shown it to being about twice as effective in terms of actually decreasing the amount of viral particle transmission. So from about 40% to about 90% when you're able to do both. But again, any layer of masking does provide a significant amount of protection. So we're not saying that necessarily everyone has to double mask, but we want everyone to mask when able to. There's obviously certain populations of kids, there's certain populations that may have challenges doing that for a number of different reasons. And then we have to adapt those other slices of cheese to create a more effective kind of layered strategy of decreasing transmission.
Great. Speaking of respiratory issues, there's a question about asthma, and this has come up quite a bit actually for both kids and adults. And we believe that at least some families who are deciding not to have their kids go to school at this time are concerned because their child has some kind of reactive airway disease issue. So how much of an issue is that for people to worry about with COVID?
So asthma is something that we don't have a ton of data, obviously, with this in terms of the specific risk profile for a kid or an adult with reactive airway disease or asthma in terms of COVID. But we do know that there is a theoretical, much higher potentially higher risk of getting COVID with someone that has asthma, particularly if it's uncontrolled. So we kind of categorize asthma kids as having mild, moderate to severe. And we know kids that fall into that moderate to severe group, particularly the severe group, do potentially have a higher risk. And so a lot of the emphasis is really in trying to best control our asthma with preventative medications, talking to your doctor about that. Asthma by itself should not preclude a child from being able to participate safely in school, but it does emphasize that importance of making sure that we're being medically kind of managed as effectively as we can to minimize the risk. The risk is really of not necessarily of getting COVID more commonly than any other child, but of getting more sick from COVID because of that reactive airway component that comes with asthma.
Okay. Great, thank you. I'm going to jump around a little bit just because of the various topics that kind of connect. One is the issue about vaccines. So there were multiple questions about that. You mentioned that, it's looking possible that not only the Pfizer, which is approved for 16 and up, but other vaccines might be approved for younger ages. Do you have any other inside information? Do you think there's a chance that by the fall it'll be possible for even elementary kids, but certainly, the middle and high school kids to be vaccinated?
Well, I wish I had a great inside scoop. We're very lucky to have the 3 vaccines currently approved, and it looks like there may be a fourth coming soon. And so we're certainly recommending to folks that regardless of what is available to them, if they have an opportunity to get vaccinated, whether it's Pfizer, Moderna, Johnson & Johnson, that they all really are effective. And so we recommend getting them regardless. We do think that based on the studies, it's possible that Moderna and Pfizer may be available for younger children soon, but really after 16 at this point, we really are encouraging when your number is called for anyone over 16 who is eligible and able to receive it, it's been shown to be safe. I hope that for our high schoolers that it comes as soon as possible. I think we're all hoping that summer vaccination for our high schoolers will happen. But I think for those younger kids and down to elementary school, we're talking longer. But I think it's also important that that we realize that when we decrease transmission of our adults, that's where we've seen, particularly in the school setting, it's really been adult to adult transmission and not child to adult or even child to child. And so when we get our adults vaccinated, we will be able to really decrease any sort of transmission. So that's why we have really felt that in-person learning is not contingent upon all of the kids being vaccinated, because the transmission will be cut so dramatically when the adults achieve a high vaccination rate.
So that question actually relates to this new guidance or updated guidance around distance between children versus distance between children and adults and other adults. And so we had questions. So why is that? Is it simply that kids are less likely to shed? Is it that their droplets are dropping to the ground because they're short? What is it that's going on that between that 3 and 6 feet?
And that's a great question. And again, this is one of those evolving pieces that we've been learning more and more about. And we don't know the exact reason. We don't know the exact reason why kids are much less susceptible towards getting this virus than adults. We know there's some factors in terms of which receptors are in kids versus in the nasal pathways versus adults. There's different immune system responses in kids versus adults. And so we know, just generally speaking, there's a significantly decreased risk profile of children, particularly younger children, from getting coronavirus, regardless of distancing. And the distancing recommendation changes have really evolved more so based on empirical experience. So the World Health Organization recommends 1 meter, which is about 3 feet. And that's been the standard in almost all the countries in Europe. And there's been studies in Norway, Switzerland, Australia, Italy that have looked at that and seen that 3 feet is a very effective means. They've been seeing no outbreaks as long as they're keeping those other layers in place. In particular, the important ones are masking and those stable cohorts. And those studies have been replicated all throughout the country as well. There's been studies that have been in the media, North Carolina, Chicago, Georgia, New York, that have looked at the same thing to see whether or not the distancing differences between 3 feet and 6 feet changes the risk profile of transmission. And almost all of those studies have shown that when those other layers are in place, there hasn't been a significantly increased risk. We don't know the exact mechanisms, but we do know kids generally have a much lower profile. And we know there's importances in those distancing because there's differences in terms of how many kids we can fit into a classroom. And that's the reason this was being studied so much, was to make sure that we could allow for the most learners possible in a safe environment. And the preponderance of evidence has shown that it is safe at those distances, which is why our governing bodies have made those changes recently.
A question, 2 related questions, temperature and asymptomatic spread. So first of all, the question about, how likely is asymptomatic spread? And is that one of the reasons that, you might not prioritize temperature taking as much, or is it simply that, temperature taking is, as you mentioned earlier, not that reliable, takes up a lot of time? Again, it was one of the things that we bought a lot of thermometers and, so there's been concerns about, well, maybe we should take the temperature because maybe the parents or guardians are not going to have time, or they won't be accurate, or how they are, they'll send the kids to school anyway. But if you could talk again a little bit about temperature taking and around that question of asymptomatic spread.
I can take that one. So screening temperatures in lobbies, et cetera, people tend to want to use those remote sort of guns that you point at the forehead. Those pieces of equipment work best when somebody has had 15 minutes to acclimatize to the ambient temperature. So imagine the backup that would occur, that each person has to hang out in a lobby space for 15 minutes. So that's why the sort of mass screening. And even from the get-go, in our facility, which is a healthcare facility where we have lots of patients, but we also have visitors, we did not do temperature screening, and really have had a safe environment because we've stuck to the other layers as well. The second piece is there's a focus on taking temperatures in children, and from the prevalence of this disease, this has not been a pediatric disease per se. And so the children who we see with COVID and symptoms have had very mild symptoms, not severe, not the fever and I can't smell and all of those symptoms. It's possible that they have it, but more of them have had milder symptoms. So if you overly relied on temperature, you might miss that as well. And then there's just the issues around inequities. Thermometers are expensive. The cheaper ones take a longer time to measure. They break relatively easily with a lot of use, so they read the wrong measure. So certainly if a family's at home and they're concerned their child might be sick, we would say take a temperature. But the key point is they're having symptoms, so you have them stay home. So even if the symptom turns out to have been allergies that day, they were rubbing on the neighbor's cat the night before and you didn't know it, it's safer to have them stay home with their sneezing and runny nose, declare that it's allergies, and then return to school, as opposed to, oh, they do or don't have a fever, they should stay home.
And maybe I'll just add two pieces. One is that we've studied the temperature screening, and what it's shown is that it's rarely identified actual folks, kids or adults, that had elevated temperatures for a lot of the reasons Dr. Atkinson McAvoy just said, and that's partially why we haven't adapted that even in health facilities. And in regards to the point, the testing, the asymptomatic testing, that's typically a type of test called antigen testing, which is the point of care testing that you can do a nasal swab or oral swab. And part of the problem with that is that it has a very high false positive rate too. So a lot of kids that end up not really having coronavirus or COVID-19 will end up testing positive. And that leads to these downstream effects of contact tracing, isolation, moving a lot of kids and potentially teachers into quarantine for a test that ends up being false positive. And that's partially why a lot of school districts have moved away from asymptomatic testing, because the prevalence is so low in kids, and the testing was resulting in these kind of false positives with a lot of downstream effects in terms of allowing our as many kids as possible in the education setting.
Great, thank you. I have two new questions that came in, both about cohorts, and I'm going to try and connect the two. One of them has to do with just trying to understand how the participation in multiple cohorts actually affects transmission risk. So a child who maybe also goes to after school. And then there's someone who's asking, specifically about a child who has disabilities, who during a normal day would interact with different adults, an aide or people circulating between different cohorts, and how that might also be a factor as well. So if you could speak to that.
Sure. So the cohort recommendations are really a lot more based on the contact tracing piece that Dr. Rogers talked about. So we want to be able to identify potential folks that had high risk exposure for a child that we presume, or a teacher that presumably may have COVID-19. And the more cohorts that are interacting, or the more high level contact or exposure, the more challenging that gets, the more downstream effects that has in terms of kids that will have to quarantine. We know that even in different cohorts, as long as we're following these kind of layered cheese, we can significantly mitigate the risk. But really, that mingling between cohorts is primarily to limit that cross-contamination, so to speak, and the impact that can have when we have a potential positive case, in terms of how many people we need to trace, and what the effect that is in terms of how many people need to quarantine and isolate and test subsequently from that.
And again, you're using the 6 feet and 15 minutes as the rule for contact, right? So, because I've got another question here about, what about kids running around during recess, when they're just running around, and, is that really going to be considered another cohort, or, really can't they run free a little bit and not be considered really mixing in the same way being in a shared spaces?
I think it's a great question, Natasha, and that's what folks are asking. And I see a lot of questions around, but how, these young kids, how are we going to keep them from being so excited to be together and to see each other? And I want to be, we're always very cautious of over-interpreting our data. So we want to make sure we're not, finding things that we want to see. But I will say two of the really good studies that we're basing a lot of this evidence on occurred in Wisconsin and in Massachusetts around the masking and distancing. And in both of those studies, actually, the 3 feet, 3 to 6 feet was not observed during sort of recess, outdoor time, passing in an outdoor setting. And in Wisconsin, actually, even in hallways, they said they weren't able to keep 3 feet in hallways. And they still found an incredibly decreased rate of transmission compared to that of the community. And so I do think, particularly outdoors where the ventilation is exactly what we hope for, that we don't have to worry as much if they are coming into contact with each other. Again, with the primary thing, as Dr. Kapadia was saying, really being the universal masking. But for short periods of time, they're going to be within 3 feet of each other. And what we know from these other population-based observational studies is that didn't seem to increase the risk of transmission.
I have a question about, we've got spring break coming up, and, people are anxious, particularly maybe some of the family members have been vaccinated and wanting to see grandma, or, have grandma come see them. And so I've got a question about What's the responsible way to behave when not in school? Can we take low risk vacations like camping? What is this about not traveling 120 miles away? What's that magic number about? Is that about the variants that we're mixing? So if you could speak to that as well, please.
Well, I can start. I think some of the concern about travel is, as you said, Natasha, when your local community has been able to decrease, as well as the Bay Area has been able to do, certainly we don't want to, necessarily introduce, whether it's variants or just go into areas of higher community prevalence. And yet, I think it's important to note that the state guidelines have allowed Bay Area residents at this point to travel a little bit more freely. Certainly, there's still a recommendation that if you go out of state for your spring break, that you do, that is recommended that you do quarantine for 10 days prior to return to a school or work community, if that's possible for you. And I think it's all about really making good choices about your interactions. And so camping outdoors, again, use the same strategies that we're talking about for a school-based setting, that being outdoors, camping is a great way to decrease that risk, and potentially to meet and gather with people outdoors with masks is a great way to see family. Again, as long as you've taken precautions, and you yourself are the only one who knows, sort of, there are these great graphics around the bubble you think you're in and the bubble you are in. And I do think that that's important to try to be honest about, because really, ultimately, all of this comes down to trust. And I think relationship-centered decisions, and really being a member of a community and taking that responsibility seriously.
You have
I just want to remind people about visiting. It depends on the family member that you are visiting, their health status, their age, because they might be at risk. So when we're traveling, or who we're in contact with. So we're going to still do the same mitigation factors, distancing, masking, even if we travel. And if you have loved ones who are at risk, they have been eligible for the vaccine now, sort of for several weeks. So if it's important to you to go visit family, it should be important to make sure people get as much protection, including having elders be vaccinated or people who are fragile vaccinated.
And the CDC has some great updated guidelines from a few weeks ago about the interactions after getting vaccinations. So now we're able to go into a household of another family that's been vaccinated, whether grandma and grandpa have been vaccinated and you've been vaccinated, you can go without masks indoors if it's a single household. They're also saying it's okay to go to a single household without vaccinations if it's just one single household without masking indoors. So those guidelines, there's a lot of different scenarios. So it's good to kind of look at that because that's a picture that has been changing as our vaccination rates have increased over the last few weeks and months.
And maybe I'll just add one more thing, and that is, like, we know that people have a different risk tolerance. And I think it's hard. There's guidance that is, on the state website, on local websites, but still ultimately, what is risky to you based on your health factors or other details might be slightly safer to someone else. And I think, Bob Wachter, who is the chair of the Department of Medicine at UCSF and has become a Twitter sensation. So those of you who have followed Dr. Wachter, he talks about the risk of being in a space where you don't know anyone and everyone's asymptomatic. And so that number of the % positive of asymptomatic tests is sort of a nice way to think about who, if I come into contact with 20 people, will any of them be asymptomatically positive for COVID-19? And that number has come just so dramatically down that it certainly gives some of our communities at least some sense that even in those who are completely asymptomatic, I believe in San Francisco County anyway, the last was like 0.8% of asymptomatic tests are coming up positive, which is just extremely low from where we were at the surge. But that number means different things depending on how you interpret it.
Thank you.
For your family.
How much more? I have a few more questions, but also want to be respectful of your time. What's your preference?
We could do a couple more.
Okay.
I'm trying to answer some in the chat as we go.
Oh, thank you for that. We actually are a couple of questions that maybe could be answered both by Dr. Stevens and the rest of you. And one of them has to do with how it is that we can really know how many cohorts someone is a part of. That's kind of goes to that question that Dr. Rogers, you were saying about the, the bubble you think you're in versus the one that's like, oh yeah, but we also did our neighbor with, so should we be reminding families what a cohort is, asking them to reduce, the number, while we are internally, have our own protocols about how many cohorts we're counting a particular child as being in. But how can we do that? Be really be sure that we're assessing risk appropriately, or are we just going to take our best crack at it?
I might start with sort of my answer and how I framed it for myself as a parent of 3 kids and as a pediatrician. The loss of school, in-person education for my children on their emotional and developmental well-being, all of the touchstones of one missed 8th grade graduation last year, the other one will miss 8th grade graduation this year. They missed their trips to DC, all of those normal things. A priority for me is for them to be able to return to in-person learning. So that may involve some sacrifices around, until we know that we've gotten it under control, how we can keep them safe at school, have them stay in school, keep their teachers safe, keep the custodial staff safe. So I think the approach of all the families is to really prioritize education and be thoughtful around exposures. It's not all or nothing, but if it's important to participate in soccer, let's wear our mask for the entirety of the soccer practice, even if our ability to run around the field is curtailed a little bit because I'm not so conditioned about running in the mask. It's sort of making this a priority. And I think each family has to reflect on that. It will be impossible to police. We know the more exposures, high risk exposures, no masks, being really close, decreases the chances that this will be successful. So I think that's the way I would frame it, is that we've learned that we rely on each other so much as a society, and that I believe that children should be our priority. So let's behave in a way to allow them to return to as close to normal as they can get.
Great, thank you. Yes, I'm seeing a lot of questions that are really aimed at that. People are trying to understand how they can participate in making sure that they're behaving safely, both for their own family, but for the good of the community as a whole. And that's clearly how we're going to come out of that. We also have other questions that really, I think, hopefully will be addressed tomorrow night. We have another information session that's being hosted by our facilities department that's going to be talking about our cleaning protocols, for example, that a lot of people are still very concerned about, and ventilation and so forth. So we'll be talking about that as well. We could certainly keep you here all night with more questions, but that's probably not fair. And we are looking forward to possibly partnering with you again in a few weeks, as we begin to reopen. We're beginning on the very soon, a week from today, with our TK to 2nd grade, and then after spring break with bringing some older children back onto campus. And I'm sure that our questions will continue to evolve, as will guidance and everyone's understanding, and we're really grateful to you. Dr. Stevens, did you have anything further you'd like to add?
No, let me just, on behalf of the district, thanks to all 3 of you for being here this evening, Dr. Rogers, Dr. McAvoy, Dr. Kapadia. We really just appreciate the expertise that you've brought. I know that a lot of parents have just been very hungry to get some straight talk about all of these different health concerns and to try to get up to date. It's just been hard for the average person, myself included, to just try and keep up with all of this sort of advancing knowledge about COVID. So our thanks, we really appreciate it, and we look forward to a continued partnership.
Thank you for having us.
Thank you again. And this recording will be available on our website. This will be as eternal as the internet. Thank you.
Good night.
Thank you so much.
Thank you so much. Bye-bye.
Thank you. Bye-bye.